Good afternoon, respected judges, dear teachers, and my dear friends. Today I am going to present my paper on cognition evaluation in normal tension glaucoma using Montreal Cognitive Assessment Questionnaire. Normal tension glaucoma is an exception in the glaucoma family where the major risk factor of an increase in intraocular pressure is missing. If not an increase in IOP, then what are the other risk factors? There are many pathophysiologies being proposed, of which a neurodegenerative mechanism due to impaired CSF mechanics dynamics brings the normal tension glaucoma closer to other neurodegenerative disorders. Cognitive impairment is the hallmark of neurodegenerative diseases, and this study was done to find out any potential association between normal tension glaucoma and cognitive impairment. Our primary objective was to compare the prevalence and severity of cognitive impairment between individuals with normal tension glaucoma to a control group. Secondary objectives were to assess the specific cognitive domain affected in individuals with normal tension glaucoma and to find any association between risk factors for NTG and cognitive impairment. It was an observational cross-sectional study done at a tertiary eye care hospital in Kerala. We had 25 NTG patients and 25 age, gender, and education status matched controls with normal IOP without glaucomatous nerve head changes. Study period was for 2 months. These are my inclusion and exclusion criteria. Demographic and clinical data were collected and cognitive function was assessed using MOCA questionnaire. Now, what is this MOCA? Montreal Cognitive Assessment was developed by Dr. C.R. Nasruddin in 1995 in Montreal, Canada for the detection of mild cognitive impairment. Today, it has been used as a highly validated tool with a sensitivity of 90% and specificity of 87% used in clinical research all over the world. We completed the training and obtained certificate for administering and interpreting MOCA. This is how the MOCA questionnaire, these are the various domains tested in MOCA. It is printed on one side of an A4 size paper. A score of more than or equal to 26 is considered as normal. However, these scores can vary according to the race and ethnicity. So we took another study based on Milani et al. And we took these criteria, 19 and 23 also in our study. These cutoffs were also applied in our study. There are many versions of MOCA available. We used the Malayalam version, which was validated in 2015 by Sri Chitra Tirunal Institute for Medical Science and Technology, Trivandrum. You can see visuospatial function of a participant being assessed here. He's asked to draw for trail making, copying a cube and drawing a clock. Now he's copying a cube correctly. Now he's asked to draw a clock with the correct contour, with the correct all the numbers and hands of the clock depicting a given time to him. This is another participant. She has completed trail making, but it is incorrectly done. She has tried to copy a cube, but it is also incorrect. And she is not able to complete a clock drawing. Similarly, all the other domains were tested. The collected data was statistical analysis were done. We had 25 NTG patients and 25 age, gender, and education status matched normal participants. 56% of them were males. 56% were in the age group of more than 60 years. 32% had an education up to higher secondary school certificate. These are the various clinical risk factors I looked for. The prevalence of cognitive impairment was 88% in the normal tension glaucoma and 20% in the control group. Even after stratification for race and ethnicity based on the other study, the prevalence was still 72% in normal tension glaucoma and 12% in control group. Among the 25 NTG patients, we had 14 with moderate cognitive impairment, 8 with mild cognitive impairment, and only 3 had no cognitive impairment. Among the various domains affected, visuospatial executive functions, delayed recall of memory, and memory index score were found to be significantly lower in normal tension glaucoma as compared to the control group. There was also a negative correlation obtained between IOP before treatment and the MOCA score. There are very few reports from all over the world using MOCA for cognition assessment, that too in NTG, and very, very few from India. We got a study by Mulani et al. Where they used a telephonic version of MOCA, and they found that NTG status was associated with a higher prevalence of impaired cognition than high tension glaucoma. There is another similar study to ours that was by Bullitt et al. Their findings were also similar to ours, but they used mini mental status examination scores. However, studies have shown that MOCA has got a very high specificity and it is more sensitive as compared to MMSE. In our study, there was a statistically significant difference in visuospatial and executive functions. These are the functions of the frontal lobe. Trail making was found to be difficult for all NTG patients. Only 16% of them were able to copy a cube. Clock drawing could be completed by 48%. Also, delayed recall memory. Memory was another domain affected. Memory index score. These were also lower in the MIS group, in the NTG group. Now, why is this so important practically? We cannot rely upon intraocular pressure for the progression, for assessing the progression. In case of NTG, we have to depend upon visual field. But can we really do that? Because studies have shown that a mild cognitive impairment in glaucoma is associated with increased false negative reports that can lead to an overestimation of mean values. So are we looking at a real true progression, or are we incorrectly treating a false worsening of the condition? We need to have an optic nerve assessment and evaluation mainly, and we have to depend on that. We can also, keeping the vascular theory of NTG in mind, we can assess the vessel density using newer modalities like MOCA, the OCT angiography for the same. So are we looking at eye being an early biomarker of dementia or neurodegenerative disorder? Our study highlights the importance of cognitive impairment in the screening of NTG. These are the limitations of my study. To conclude, cognitive impairment was found to be significantly associated in NTG, specifically impacting visuospatial and memory domains. These are my references. Thank you. Yes. Yes, madam. Yes, madam. Bromonidine is supposed to be neuroprotective, so we hadn't we had 25 patients only, and all of them were on drugs that was on prostaglandin analogs. Only 10 were having prostaglandin analogs along with bromonidine, but we couldn't get a statistically significant result with the MOCA score. That is why I didn't include that in the presentation. Yes, madam. Okay, madam. Yes, madam. Have a yes, madam. Yes, madam. Yes, madam. Thank you, madam.
I'd also say well done. My sort of issue was in the original case selection and the controls. Probably it's not very clear in the presentation, but how did you assess the capability of your patient group initially to be able to do this MOCA? Because your educational standards were pretty.
Yes, 32% were up to higher secondary school, 28% had up to 10th standard, 26 actually had up to graduation, and 12% were actually in a professional degree, but 3 out of 25 in both the groups had only primary education. For that, in MOCA, we add a +1 score. If they don't have 12 years of education, we add a +1 to the total score. However, it is not being, there is no normative data for Indian population. These are all for Caucasian population. We need Indian studies to have, to compare that correctly to our socio-economic status and education levels, sir.
I think it's a very good piece of work.
Thank you,
and I think you should work towards sort of getting it published as well.
Thank you, sir.
Okay.
Thank you, sir.